All right, this is chapter 22. We're going to talk about nursing care of patients with hypertension. Oops, I'm going to go back. 41% of non-Hispanic African Americans are likely diagnosed with hypertension, 28% of Caucasians, and 22% of Hispanics are diagnosed with hypertension. So it is affects a lot of people. Also, it's important to make note that, okay, even though 29% of all U.S. adults have hypertension, and that's age 18 years or older, it's 7% of adults ages 18 to 39, and 67% of those age 60 or older have hypertension. So, when taking a blood pressure, just one kind of basic thing to keep in mind is to clean your stethoscope. There is evidence that, stethoscopes can carry lots of icky diseases. So, it's important to clean at the start of every shift, and then also to clean between every patient use and with each hand hygiene. So, just a little note. When taking blood pressure, make sure you use a calibrated instrument. Have that patient sit quietly for 5 minutes in a chair, not the exam table with their feet on the floor. They should not have their legs crossed because that can impair circulation, and the arm should be supported at heart level. Use a blood pressure cuff bladder that encircles at least 80% of the arm. Should take 2 blood pressure measurements, wait in between, and then tell the patient they're recording or they're reading. So there is a short video to watch on that if you can have time. So hypertension, normal blood pressure is below 120 over 80. The 120 is the systolic, 80 is the diastolic. So if these are elevated, the average of 2 or more readings on different dates, and the highest reading determines their category. So if you look on page 414 in your textbook, there's a blood pressure category in measurement. So we talked about the normal, systolic, normal, diastolic, less than 120, less than 80. Prehypertension is diagnosed when systolic is 120 to 139, or diastolic is 80 to 90. So recommended that that patient follows up with their provider every year. They should, encourage them to do lifestyle modifications. Stage 1 hypertension, systolic is 140 to 159, and diastolic is 90 to 99. Recommended that that patient follows up in 2 months, and they engage in lifestyle modifications, and they start in with some kind of drug therapy. Stage 2 hypertension, systolic blood pressure is 160, or diastolic is 100 or higher. So you notice that it's or. So if this patient is, say, 115 over 85, they're still in that prehypertensive category. And we talked about this follow-up care. If it's greater than 180 over 110, that can be a hypertensive emergency, so that demands immediate treatment. So blood pressure, I talked about that a little bit in the last unit, but that is the pressure exerted by the blood on the walls of the blood vessels. So factors that affect blood pressure includes cardiac output. So that's how much the heart is beating. So remember, cardiac output is a function of stroke volume and heart rate. So if that heart rate increases, blood pressure increases because cardiac output increases. If the force of contraction or the amount of blood pumped with one ejection increases, that also can increase blood pressure. Peripheral vascular resistance, so that's the force that the blood or the heart has to overcome to pump the blood out into the vessels. So if those vessels are smaller, if they're decreased diameter, if they've got plaque buildup in them, which also reduces diameter, that's going to increase that peripheral resistance. Another one is vessel stretch. So, normally our veins are a little bit elastic. They have a little bit of give. If they're hardened and diseased, then that can elevate blood pressure. Also, another one is blood viscosity, how thick our blood is. If it's thicker, it's going to increase that blood pressure. And then blood volume. If we've got a high amount of blood volume to pump around, that's also going to increase blood pressure. So all of these are pretty much directly related. So you increase cardiac output, increase blood pressure, increase peripheral resistance, increase blood pressure. I guess except for vessel stretch. Increase blood viscosity, increase blood pressure, increase blood volume, increase blood pressure. So they're all directly related. So pathophysiology, a lot of hypertensions are primary or essential. We don't know what the cause is. It just happens. Secondary hypertension, there is a known cause. So that could be, some other problem like a kidney problem, some type of hormone dysfunction, that type of thing. And then there's also what's called isolated systolic hypertension, where the systolic blood pressure is greater than 140, but the diastolic is less than 90. And that occurs more often in the elderly population. So hypertension signs and symptoms, oftentimes there's none. Patients will have no symptoms at all, but they'll have high blood pressure, but it's still doing damage to that patient, patient's tissues and organs and that type of thing. So that's why it's often called the silent killer. Rarely patients will have symptoms of headache, bloody nose. They may be anxious. They may have shortness of breath, that type of thing. And then target organ disease, they may have that as well, where they have damage to the blood vessels of their heart, kidney, brains, and eyes. So diagnosis of hypertension, it's based on that patient's risk factors, any previous hypertension. So we want to look at their history. We want to look at any signs and symptoms that they have. We also want to look at their kidney and heart function, any medications that they're taking, and then blood pressure readings. And typically patients will be required to be monitoring their blood pressure at home, to see how it is. Diagnostic tests can do an ECG, look at the blood glucose, because we talked about that in the last section, that patients that have diabetes are likely to have hypertension as well. Look at their hematocrit, so that's part of their red blood cells, and can indicate increased viscosity. We look at their potassium, we look at their calcium. We can also look at their lipoprotein, cholesterol, and triglyceride levels as well. So hypertension risk factors, non-modifiable, those are unable to be changed. Modifiable, those are changeable. So non-modifiable risk factors include family history. There's nothing we can do about our uncle that has hypertension or our mom that has hypertension. Nothing that you or any patient can do about that. Can do nothing about their age. They can do nothing about their ethnicity. And if they have diabetes, they have diabetes. They can affect how they manage that diabetes, but they are at increased risk of hypertension if they have diabetes. Modifiable risk factors are things that patients can do something about, like their weight. That's a risk factor. Their diet, how much sodium they have, how much caffeine they have, that type of thing. How much alcohol they use, if they exercise, if they smoke, how they handle stress, if they get adequate sleep. Those are all modifiable risk factors that can affect blood pressure. So hypertension treatment, if there's low or no risk, and they're hypertensive, typically they'll just recommend lifestyle changes, so like stopping smoking, limiting alcohol, decrease salt intake, make sure you're getting adequate nutrients, reduce saturated fat and cholesterol, maybe lose weight, get regular exercise, get adequate amount of sleep. It's interesting your textbook cites more than 5 hours. Well, I would be a zombie if I only got 5. Anyway, if blood pressure is greater than 140 over 90 over 6 months, the goal of treatment is to get that down below 140 over 90. If it's a patient that has diabetes, kidney disease, or proteinuria, we want that blood pressure down even lower, because they're already at risk for kidney damage and other damage from vascular changes from their diabetes if it hasn't been managed correctly. So typically we want that a little lower. So hypertensive treatment typically goes along with the lifestyle changes that we just talked about, as along with antihypertensive medications. And typically what patients will be started on initially will be thiazide type diuretics. So what those are low potency diuretics that help to decrease fluid volume. So they help the kidneys to function a little bit more adequately to help to decrease that fluid volume, which in turn will decrease the blood pressure. And then there's lots of other combination medications as well. Read through page 420 to 422 in your textbook on all the different types of medications, what their side effects are, what are some of the nursing implications as well. So make sure you look at that. Just in general, we'll talk about some of these diuretics. What those are going to do is to reduce fluid volume. So they're going to increase urine output, reduce that fluid volume, reduce blood pressure that way. There's alpha blockers, and what they do is block sympathetic nervous system on smooth muscles. So they, what happens is they have vasodilation. So if we dilate those vessels, we are reducing peripheral resistance and reducing blood pressure. Patients can also go on beta blockers, and what those will do is block the heart rate from pumping so hard, so that will decrease blood pressure that way. So if we decrease cardiac output, remember we're going to decrease blood pressure. So that's what beta blockers do. The last one we're going to talk about is calcium channel blockers. And what that does is it prevents extracellular calcium from moving into the cell, which causes vasodilation. So it's another vasodilator. So if we dilate those vessels, it's going to decrease our peripheral resistance and decrease our blood pressure that way. I guess there's more that we're going to cover. We've got angiotensin converting enzyme inhibitors. So in that last slideshow that we talked about the renin-angiotensin converting system. So we talked about angiotensin 2, that specifically at the end of that whole big deal, that is what causes that vasodilation, or vasoconstriction, excuse me. It causes, it's a very potent vasoconstrictor, so it causes blood vessels to constrict and become smaller. So if we inhibit portions of that pathway, we are going to inhibit that angiotensin from being released and hence prevent the vasoconstriction. There's also central agents that may work to dilate the blood vessels in the heart. What I can think of for those central agents would be like nitro, which is going to directly dilate vessels in the heart. And then there's also peripheral agents that are going to help to dilate blood vessels in the periphery, and vasodilators. And oftentimes patients will be on an aspirin regimen as well. So if they do have high blood pressure, they're more at risk of strokes, heart rates, that type of thing. And typically patients will take their aspirin at bedtime because the likelihood of them having some type of event like a heart attack or that type of thing is more over the night or early in the next morning. So that's why it's typically recommended for patients to do that in the evenings. Complications of hypertension are atherosclerosis. So that is a narrowing of and hardening of those blood vessels. So that is a risk factor. They're also at risk of coronary artery disease. So, of them having a heart attack, that type of thing can precipitate that. Or myocardial infarction. Coronary artery disease is where a patient has some kind of blockage in blood flow in their coronary arteries. And remember, those coronary arteries are what feed the muscle of the heart. They're also more at risk of a myocardial infarction. Left ventricular hypertrophy, because remember that left ventricle is the ventricle that pumps the blood out to the rest of the body. So if we have high blood pressure, that left ventricle is working really hard to overcome that resistance to pump the blood to the rest of the body. So if it's working hard, it can grow in size, and then eventually it can wear out, which we're going to talk about that later. Also, patients are more at risk of stroke, as well as kidney and eye damage. So a hypertensive emergency, so this is going to be when the systolic blood pressure is greater than 180 or diastolic blood pressure is greater than 120. So patients have a risk for or progression to target organ dysfunction. So the body has to overcome so much resistance to pump that blood around that organs are not getting enough blood. So this could be a myocardial infarction, could be heart failure, could be a dissecting abdominal aorta, which we'll talk about that later as well. So we need to intervene immediately to reduce that blood pressure to protect those target organs. And typically, patients will be put on nitroprusside or nipride IV to help dilate those blood vessels and reduce the patient's blood pressure. Hypertensive urgency, so that is severe blood pressure elevation without target organ dysfunction progression. So patients will have severe headache, nosebleed, shortness of breath, and severe anxiety. And typically patients will get an oral medication for that to dilate those blood pressure or those blood vessels. So there's different nursing processes, can be deficient knowledge on page 425 in your textbook. Make sure you read through those interventions and rationale for those nursing diagnoses or those nursing care plans. Those are really important. So make sure you look through those. Patient education, for someone with high blood pressure, it's going to be important that they measure their blood pressure lifelong and that they take self-care measures to make sure they're managing that, and as well as following their prescribed medical regimen.